good afternoon, everyone. I am Dr. Jillian Tamora Lactao. I would like to thank the section of Cardiology for inviting me to give a lecture today. So my talk will be about the invasive and non-invasive mechanical ventilator management in cardiovascular medicine. So I have no disclosures, and my lecture aims to discuss the following: respiratory physiology and mechanics, modes of oxygen delivery, positive pressure ventilation in the cardiac intensive care, modes and applications of oxygenation, the high flow nasal cannula, non-invasive positive pressure ventilation, the CPAP and the BPAP, invasive mechanical ventilator, applications in cardiogenic pulmonary edema, cardiothoracic surgery, and heart failure. So before we discuss the cardiothoracic hemodynamics and mechanics, we will review first the respiratory system. Of course, you have two components, the lungs and the respiratory pump. The lungs comprises of the bronchus, the lungs, the alveoli, which are the smallest unit in the lungs, and the capillary basement membrane. While in the respiratory pump, you have the phrenic nerve, the intercostal muscles, the diaphragm, the CNS, the thoracic cage. And if there's any dysfunction in the lungs, we call it the pulmonary failure. And for any dysfunction in the respiratory pump, we call it ventilatory failure. So for any hypoxic respiratory failure, the treatment choice is oxygen, while if you have hypercapnic respiratory failure or failure of the respiratory pump, you give oxygen and ventilatory support. So ventilatory support can be invasive or non-invasive mechanical ventilators. So for gas exchange, as you can see in the diagram, the normal cluster of alveoli is seen with a normal capillary. The delivery of oxygen is on the left side, and on the right side, the oxygen is picked up. The carbon dioxide travels dissolved in blood. It travels to blood across the capillary walls and into the alveolus. Ventilation occurs readily. The clearance of carbon dioxide has two variables. Number one is the respiratory rate. And if there is an increase in production, you increase the respiratory rate of the patient. And if there is increased rate of elimination, the tidal volume adjusts. Minute ventilation is computed as respiratory rate times tidal volume. Oxygen is transported in the blood through the hemoglobin oxygen transport in the RBCs. So it goes to the alveoli, to the concentration gradient, to the capillaries, into the RBCs, and it binds with the hemoglobin. If you can see here, the blue dots or the blue X's are the oxygen, and when it goes from the alveoli to the capillary basement membrane into the bloodstream, these marks with X are your RBCs and hemoglobin, and every molecule of oxygen attaches to the hemoglobin. So as you can see in this slide, this is the spontaneous breathing illustration of a resting state. You can see here the relaxed intercostal muscles and diaphragm. The endothoracic pressure, known as your pressure pleura, is also known as the intrapleural pressure that influences the cardiovascular physiology. At rest, the functional residual capacity is determined by two forces. Number one, the thoracic wall with a tendency to spring outwards, and number two, the alveolar units, which tends to collapse. In the resting state, the pleural pressure is slightly negative. You can see in this diagram the oxygen delivery, and when acute respiratory failure develops, there are mild and severe cases wherein you consider first giving, number one, oxygen support. We have the low flow oxygen therapy, escalating to high flow oxygen therapy, non-invasive ventilation, invasive ventilation, and lastly, invasive mechanical ventilation and ECMO. So for low flow oxygen therapy, the first modality we can use is the nasal cannula. It's a fixed flow rate of 2 to 6 liters per minute, and the FiO2 is estimated to rise 3 to 4% with every liter per minute provided. The FiO2 is not fixed and varies from breath to breath. Second is the Venturi mask. It mixes oxygen with room air in a fixed ratio and provides FiO2 of 24 to 60%. The non-rebreather mask is a reservoir bag filled with oxygen and it provides an FiO2 of 85 to 95%. This slide shows the hemodynamics of spontaneous inspiration. So the contraction of the diaphragm in intercostal muscles render the pleural pressure more negative with resultant hemodynamic effects. So the passive expiration through the alveoli and chest wall recoil, making the pleural pressure less negative. So you can see in the spontaneous inspiration, the venous return increases, the preload increases, and when this happens, the RV afterload decreases, and here, the LV afterload increases. When you say positive pressure ventilation, you are talking about non-invasive ventilation. You have the CPAP and the BPAP. And for invasive ventilation, that's when you intubate the patients and hook to a mechanical ventilator. So anticipating the physiologic changes, again, when you apply a mechanical ventilator or positive pressure ventilation, there's an increase in afterload due to the compression of the pulmonary capillaries and increased pulmonary vascular resistance. There is a decreased LV afterload due to barrier response from initial inaortic pressure, and the pleural pressure becomes positive from positive alveolar pressure and airway pressure. So in hemodynamics of positive pressure ventilation, the venous return decreases, the preload decreases, the positive pleural pressure compresses the RV and LV cavities. There is decreased again here, venous return, the RV afterload increases, and the LV afterload decreases. Increases in the intrathoracic pressure affects both ventricles. The distended alveoli leads to the increased afterload of the right ventricle. Therefore, it has increased peripheral vascular serve as well. The transpulmonary pressure is the alveolar pressure minus the pleural pressure. When a mechanical ventilator or PPV is used, there will be an increased transpulmonary pressure, a direct effect on RV outflow, which compresses the pulmonary arteries and increase the PVR and RV afterload. So what happens in pleural pressure? So during spontaneous breathing, there is a negative or decreased pleural pressure, and the interventricular pressure becomes more negative relative to the systemic pressure. Therefore, this increases the afterload. During positive pressure ventilation, there is an increase in transpulmonary pressure, the direct effect on the RV outflow, which again compresses the pulmonary arteries and increases the PVR and the RV afterload. In terms of the pleural pressure, it increases, which has a direct effect on the RV inflow and a direct effect on the LV outflow. As mentioned earlier, what happens is there is decreased venous return, decreased preload, the aortic pressure increases, the baroreceptors are activated, there is reflex vasodilation, and the SVR decreases. PPV in patients with RV and LV dysfunction has direct effects from PEEP. It decreases the LV afterload to facilitate LV unloading. It decreases the LV diameter to improve cardiac output, increases transmural pressure for improved cardiac output as well, and increases the alveolar pressure at the end of expiration to improve compliance and prevent alveolar collapse. In gas exchange, it reverses hypoxic vasoconstriction, it decreases in preload to improve pulmonary congestion, and improves ventilation perfusion matching, which is very helpful in oxygenation. The PPV optimizes gas exchange and it improves metabolic demand and peripheral perfusion. In terms of ventilatory support, it improves the work of breathing by improving tissue perfusion and decreased myocardial consumption of oxygen, and improves hypercarbia and acidosis. This slide shows the relationship between the alveolar volume over pressure and pulmonary vascular resistance. Take note that atelectasis and overdistension can increase the PVR. So at low lung volumes, atelectasis can increase the PVR due to collapse of the alveolar capillary unit and hypoxic vasoconstriction. And at very high P alveolar pressures, it will compress the pulmonary vessels and again increase the PVR. Opening the alveoli with the appropriate PEEP will favorably tether vessels and improve the PVR. So now we go to the high flow nasal cannula. The high flow nasal cannula decreases the work of breathing, tachypnea, decrease the rates of intubation, and increase the oxygenation. So it's a precise and accurate FiO2 delivery and generates a low PEEP effect. The flows of 30 to 50 LPM provide a PEEP of 3 to 5 centimeter water. It delivers gas at a flow that meets or exceeds patient's own inspiratory flow, and it is able to wash out anatomic dead space, meaning it eliminates CO2 and decreases the work of breathing. It can be applied in cardiothoracic post-surgery patients in the immunocompromised as a support for intubation, bronchoscopy, and can be used also for palliative care. Advantages of high-flow nasal cannula include the following: ease of application and removal, the oropharynx is unencumbered, patients can eat, good hygiene, expectoration of secretions, they can communicate, it can improve gas exchange, monitor the breathing pattern, provide comfort, and facilitate procedures. However, it has limited capacity, it has an unsealed airway, and has high gas requirement. So how do you start high flow nasal cannula? So initial settings, you start the FiO2 at 100% and you titrate down the FiO2 to goal O2 saturations. The flow should start at 40 LPM and titrate it to patient's breathing effort. Once you start weaning the patients on high flow cannula, you start weaning the FiO2 from 100 going down, and then the flow from 60 being the maximum, or whatever flow you set the patient, you decrease it up to 20 LPM. Once you wean these patients, you can shift them to a nasal cannula to room air. So high flow nasal cannula in cardiogenic edema may improve oxygenation and dyspnea scores, but the mortality benefit is unclear. Post-extubation, it is better than Venturi mask, but it's non-inferior to NIV. The reintubation rates are almost similar. We move on now to the non-invasive ventilation, which includes your CPAP and your BPAP. Non-invasive ventilation is the delivery of positive pressure ventilation to the lungs without endotracheal intubation. Advantages include the reduction of complications, such as ventilator-associated pneumonia, increased hospital length of stay, trauma, pneumothorax, decreased sedation. It allows intermittent use and feeding is allowed. It preserves the natural airway defense. Disadvantages of NIV include aerophagia, air leak, mask discomfort, facial ulcers, slower correction of ABG abnormalities, and delayed intubation. The potential indicators of success of NIV for patients include younger age, lower acuity of illness, able to cooperate, better neurologic scores, less air leaking, intact dentition, moderate hypercarbia, moderate acidemia, and improvement in gas exchange, and clinically, patient is better within the first 2 hours. Contraindications include the following: if the patient has lack of respiratory drive, unresponsive, uncooperative, needs an airway protection, unable to clear the secretions, inability to fit interface, has a high severity of illness, hemodynamically unstable, we do not put patients on NIV. These are the physiologic benefits. In monitoring patients on NIV, you check the mental status, the clinical respiratory parameters, the respiratory rate, the exhale tidal volumes on the machine, check if the patient is using the accessory muscles, if the mask fits and is comfortable, and monitor also the arterial blood gases. So we move on to CPAP. CPAP is a continuous positive airway pressure. It's a single pressure applied throughout the respiratory cycle and recruits the alveoli to participate in gas exchange. The positive endothoracic pressure reduces venous return, and CPAP is beneficial in cardiogenic pulmonary edema. CPAP are set at a pressure of 5 centimeters water. You titrate by 1 to 2 centimeters water, and the maximum is 10 to 12. The titration of FiO2 depends on the requirements of the patient, and you titrate the parameters to your goals. The next is your BPAP. It means bi-level positive airway pressure. So this model provides additional positive pressure during inspiration. So the difference in inspiratory, which is the IPAP, and expiratory EPAP pressures creates the airflow, which promotes carbon dioxide elimination. This is beneficial in patients with hypercarbic respiratory failure. So take note here that this is the IPAP set at 14 and the EPAP is set at 6. The difference of IPAP and EPAP is what you call the pressure support. So you're giving a support of 8 for this illustration. So this slide shows an alveoli and the function of IPAP and EPAP. So EPAP keeps the upper airway open and avoids alveolar collapse, while your IPAP provides ventilatory assist, increased lung volume, and decreased work of breathing. So initial settings are for IPAP, 10 centimeters water. You can increase it up to 20 to 25. The EPAP is set at 5. The maximum is 10 to 12. Always make sure that there is a difference between the IPAP and the EPAP. Always check also the pressures in the lungs of the patients to avoid barotrauma. So you titrate IPAP by 2 to 3 centimeter water to achieve desired tidal volume and carbon dioxide, and titrate the EPAP to achieve the goal oxygenation. The FiO2 is set up to 100%, depending on the requirements. So NIV for cardiogenic edema is an established indication. It increases alveolar recruitment, decreases venous return and work of breathing, and prevents intubation and associated with decreased mortality. For cardiac surgery patients, this is often asked, the NIV improves arterial oxygenation, reduces the incidence of pneumonia, reintubation rate, and reduced readmission rate to ICU or intermediate care units. No study has been published concerning the effect of curative NIV in patients who have developed acute respiratory failure after cardiac surgery. For thoracic surgery, prophylactic use of NIV in a pre- and post-operative manner significantly reduces pulmonary dysfunction after lung resection. So in this group, the patients who were put on NIV are measured that have significantly better outcomes after 2 hours of surgery. In the 1, 2, and 3 post-op, the oxygenations were better and they had reduced hospital stay. So according to the guidelines of ERS and ATS on NIV for respiratory failure, the answer to the question, should NIV be used in the post-operative setting? The answer is they suggest that NIV could be used for patients with post-operative acute respiratory failure. So this is a conditional recommendation with moderate certainty of evidence. So for pulmonary patients and cardio patients, of course, we assess the risk for pulmonary post-operative complications. So we use the ARISCAT score. We check if there is any chance that patients may develop atelectasis, pleural effusion, pneumonia, and decreased thoracic compliance post-op. So for atelectasis, you make sure that patients do incentive spirometry, you control the pain, and encourage early physical activity. For pleural effusion, this is done specific in cardiac post-surgery cases. Check if there is fluid overload, pulmonary congestion, any infection like pneumonia. So if there's effusion, you give diuretics, you drain it, or you give antibiotics. For pneumonia, it's very important that you try to do early extubation, encourage ambulation, and keep the head elevated at all times, and treat the infection. For decreased thoracic compliance, it usually peaks on the 3rd day post-op. That's why it's very important to monitor these parameters. Post-operative care includes titration of analgesia and sedation, daily weaning checkers, ventilatory support and extubation. You decrease the O2 support to goals, prevent aspiration, and if intubated, aim for early extubation if feasible within 6 to 12 hours. Should NIV be used to prevent respiratory failure post-extubation? This study showed that NIV reduced the number of developing post-extubation failure and ICU mortality. So the rate of re-intubation, ICU and hospital length of stay, and hospital mortality were not significant. So who are the patients at risk for re-intubation? So for these cases, those who have a weak cough, frequent suctioning every 1 to 2 hours, increased sputum volume of more than 2.5 ml per hour, a GCS of less than 8, positive fluid balance during the 24 hours preceding extubation, pneumonia as the initial reason for intubation, more than 65 years old with severe chronic cardiac or respiratory disease, and reduced or absent cough leak, and those with altered mental status are at risk. So when should NIV be discontinued and invasive ventilation started? When the patient is unable to tolerate the mask, there is an inability to improve the gas exchange, and there is still dyspnea with a maximum of 2 hours. When there is a need to manage secretions or to protect the airways, when the patient is hemodynamically unstable, with ECG abnormalities, and a failure to improve mental status 30 minutes after initiation of NIV in patients with carbon dioxide retention or hypoxemia. We intubate the case. So this is the decision to intubate. Check if there's failure of airway maintenance of protection. If there is, intubate. Is there failure of oxygenation or ventilation? If the answer is yes, check if the patient is an NIV candidate. If yes, you may try NIV, but no, you intubate. And lastly, does the anticipated clinical course require intubation for these cases? So in mechanical ventilation, the objectives are primarily decrease work of breathing and reverse life-threatening hypoxemia or acute progressive respiratory acidosis. So these are the parameters on how you monitor them. You check the pulse symmetry with alarms, check the blood gases, the subjective and objective responses, and check the mechanical side for any ventilator asynchrony or air leaks. Of course, the function is for oxygenation and clearance of carbon dioxide. For the oxygenation, you have two variables, the positive end expiratory pressure, which is PEEP, and fraction of inspired oxygen, the FiO2. The PEEP is responsible for opening the alveoli, which can participate in the gas exchange. While in clearance of carbon dioxide, the two variables important are the respiratory rate and the tidal volume, which is proportional to the minute ventilation. Common modes of mechanical ventilator include the following. So you have the volume assist control, pressure assist control, SIMV, and spontaneous pressure support. This busy slide is an example of a clinician who set the patient on pressure mode and volume control mode. So you can see here the FiO2 they set, the initial PEEP settings, the respiratory rate, the tidal volume, the triggers, and the legs. So I'm just going to illustrate an example of a screen of a mechanical ventilator. So commonly, post-operatively in cardiac patients, or for someone who has cardiogenic pulmonary edema, ECS, or any related illnesses, we usually set the patients first on AC. So assist control, VC, AC-VC mode. So this is volume control mode. So as you can see in this diagram, we have the set RR, the set tidal volume of the patients, the FiO2, the PEEP of 5. Of course, you have to make sure that the ET is in place before you set the PEEP. It's very important that you know the compliance of the patient, which is this one. You know the plateau pressures and the driving pressures of the patient. And make sure that the patient is not at risk for ventilator-induced lung injury. So in this mechanical ventilator monitor, you check the peak pressures, the PEEP, the IE ratio, the exhale tidal volumes. So this is a smart machine and everything's already in the mechanical ventilator, giving you context and clues if the patient is recovering or not. So volume control has independent variables such as the volume and flow, while in pressure control and pressure support modes, you set the pressure. So this is the respiratory support in pulmonary edema. So if patients present with pulmonary edema with respiratory insufficiency, you check the patient. Is he in respiratory distress? Does the patient have oxygen desaturation? Try giving oxygen to the patient. If the patient is persistently in distress with the respiratory rate of more than 25 or increased work of breathing, you consider immediate intubation if respiratory distress is severe or there are contraindications to non-invasive ventilation. Okay, so they have two choices. The ones we discussed earlier, the NIV or invasive mechanical ventilator. If you try NIV and the problem is hypoxia alone, you can try high flow nasal cannula, you can try CPAP and BPAP. If the problem is hypoxia with hypercapnia, you want to blow off the CO2 as well. That's why you are going to hook the patients on the BPAP machine because you can set the IPAP and the EPAP. If there is improvement within 30 minutes, you will see that the patient has decreased work of breathing, decreased respiratory rate, decreased heart rate, the patient is not in distress anymore, and the oxygen saturation stabilizes. However, if the patient does not improve, you intubate the patient. This is a suggested algorithm for acute heart failure or cardiogenic shock. So you can consider potential indications for invasive mechanical ventilator if the patient has severe hypoxia, increased work of breathing, failure to respond to non-invasive positive pressure ventilation, clinical instability due to refractory shock, need for mechanical circulatory support in combination with respiratory failure, and patients undergoing targeted temperature management. So if the patient is really critical and hemodynamically unstable, you intubate. Early intubation to decrease myocardial oxygen consumption. You check also, is there RV failure or is tamponade present? Use PPV only when necessary and optimize the goals. And once you intubate the patient, these are the initial ventilator settings. Again, you may try AC, PCMB mode, volume control mode, pressure support, with close monitoring of work of breathing. You start the FiO2 at 100% and titrate it down to keep O2 saturations at 92 to 94%. Tidal volume, you usually start at 6 ml per kilogram of ideal body weight and adjust the PCO2 while avoiding volutrauma or atelectasis and maintaining, again, the plateau pressure of 30 because you do not want lung injury. The RR set at 10 to 20 breaths per minute. Adjust the PCO2 while monitoring auto PEEP. Again, for oxygenation, you may alter the FiO2 or the PEEP. And for carbon dioxide, you adjust the tidal volume or the RR. And of course, ensure proper sedation to maintain synchrony of the patient. So even if the patient is on mechanical ventilator, you are treating the patient. So positive pressure ventilation decreases RV preload, increases RV afterload, and decreases LV afterload. High flow nasal cannula oxygen can avoid the need for PPV in some patients. BPAP is preferred over CPAP when there is a need to reduce the work of breathing and or improve ventilation in patients with hypercarbia. PEEP is useful for oxygenation and to avoid or treat atelectasis, but can also be useful in unloading a failing LV. Positive pressure should be avoided if possible or used cautiously in conditions dependent on adequate RV filling, such as acute pulmonary hypertension, RV failure, and tamponade. Thank you very much for listening, and I hope you learned something from my lecture. Thank you, stay safe, and God bless.